So we did the ligaments, sternoclavicular, acromioclavicular, glenohumeral. We did the motions of the glenohumeral joint and how that drives motion at first the sternoclavicular in phase 1 and then the acromioclavicular phase 2. All of that sound familiar? Maybe confusing, but not familiar? Familiar, but confusing, but it is familiar. Okay. I would strongly encourage you to go sit down and chat with somebody, make sure it's all fresh in your head. Okay? Okay. So, scapular stabilizers. Well, how many muscles do we have? 6. 6 muscles. What are the function of those muscles? What are they trying to do? There's a simple answer. Stabilize the scapula. So we have this scapula that's got to shift, it's got to move. It protracts, it retracts, it comes sliding around this rounded rib cage, it pulls back against it, it elevates, it depresses, it rotates to give us that 180 degrees. How many degrees does it rotate?
120.
So glenohumeral moves 120, so how many degrees does the scapula rotate?
60.
60, because it makes up the rest of that to give us the 180. So we can math today, right? On occasion. All right. So from that, we have this distal action, this distal motion at the humerus that pushes up against the glenoid, up against the acromion to create some of that motion. But we have all of these muscles that are attached in and around on that scapula that facilitate that and stabilize it, where whatever else we do with that humerus is controlled. So what are those muscles? What are the scapular stabilizers? Which are the 6? Trapezius.
Levator scap.
Levator scap.
The rhomboids.
Rhomboids, major and minor.
Serratus anterior.
Serratus anterior.
And pec minor.
And pec minor. So 5 on the back, 1 on the front. Now the 5 on the back really give us this kind of dynamic balancing structure. So I'm going to grab a few and get them out of the way. All right. So the first one we see is that trapezius. And so originates where? Occiput to T12 on the spinous processes all the way down. And then it comes out to the spine of the scapula. But recognize that the superior fibers are actually coming down along the distal third of the clavicle as well as the acromion and into the spine of the scapula. Just grabbing all over the place on that scapula. So there's a lot of elevation where those upper fibers pull. So we have that one out. Now we've got a good look at the assistance to elevating it, which is your levator scap. Then rhomboids are going to grab that medial border, pull them in towards the spine, which is going to be counterbalanced in large part by the serratus anterior, which is going to pull it back. Protraction here, retraction here. That covers the majority of its actions, right? Well, we also have rotation, so depending upon which fibers we fire in serratus, which fibers we fire with trapezius, how much that humerus is torquing at that glenoid to create that rotation, we have to control all of that as well. This is a very dynamic balance of give and take. So again, if we do something that inhibits that system, then we have problems. If we shut down one of those muscles, which can typically occur within a shoulder injury, then we have some major significant issues. What's the secondary function of serratus anterior? So the principle is probably going to be protraction, or pulls it forward, right? So what else does it do?
The winging.
The winging. So it prevents, it holds that medial border and pulls it in towards the ribs. If it's not functioning right, then we get scapular winging where it pulls up and up. So if serratus anterior isn't working right, it's got weakness, what muscle compensates to help manage retraction and pulling that serratus back towards the spine, of holding the serratus medial border in towards the ribs?
Rhomboids.
These do. Rhomboids do. They're grabbing that medial border, which is very similar to the others. Is that their job? Not so much. So they're trying to compensate for a weakness we have. So normally, they're actually opposing the serratus anterior. I mean, this protracts, this retracts. We inhibit this, and now not only are we not counterbalancing, we're actually firing these more to make up for a secondary function of the serratus. So all of a sudden I have very tight rhomboids. Just to kind of hold that scapula back and in place. So you can already tell the system's already whacked out. So we did this in class. We did a shoulder punch, right? Shoulder shift, did some resistant manual muscle testing. Have a weakness within that. Okay. So if that's really tight, then what muscle makes up for it? For the action, for the retraction, the active movement that it's supposed to do. If this is just tight, then what else can step in to try to fire to assist? It's your trapezius muscle. Because it's got this line of pull to go the same basic direction of pulling, especially the middle fibers, across. And if you're firing it too hard too often, those people will tend to get increased neck sensitivity, neck pain, neck tightness, which could lead to tension headaches through here as well. So again, just hold on to that very dynamic balance. These muscles are pulling against each other in a desire to hold this stable so that we can do things with strength and with accuracy and precision at the shoulder and how we reach out and move and manipulate the world. All right. So scapular stabilizers, that's group number one. They stabilize the scap. Now the vast majority of the land mass of the scapula is actually spacing for the rotator cuff to attach to. So let's chat about the rotator cuff. This will be group number two. These are your sits muscles, S-I-T-S. Supraspinatus, infraspinatus, teres minor, subscapularis. 3 of the 4 of which we palpated specifically in class. So, supraspinous, here's the spine of the scapula. Supraspinous fossa, infraspinous fossa. Supraspinatus muscle, infraspinatus muscle. Next, coming off the back below on the lateral border, we have teres minor. Now, all 3 of these have the same insertion point, largely. So this landmark right in through here, what is that?
Greater
You've done your osteo, greater tuberosity. So let's find that real quick. So if you take your hand, start lower, work your way up, you'll come to kind of a big bump right up in here as you roll up and over it. Easier way to kind of identify it is if you externally rotate a little bit, and then take your hand over the front, the anterior portion that's now presenting. You'll feel your finger kind of roll over a cable. Do you feel the cable? Yes? Good to go? Okay. So that cable right there, that's your intertubercular groove. Break those words down. What does it mean? Inter is in between. Tubercular, tuberculosis. Tubercles, sorry. Groove means it's a groove. So what the cord you're feeling is actually the long head of the biceps tendon, sliding through that intertubercular groove. It separates the tubercles, the greater, which is the external side, and the lesser, which is underneath, which is more medial. And the only way to find medial is to externally rotate to get it to present, because normally it's tucked inside. So, supraspinatus, over the top. Infraspinatus, posterior, teres minor, posterior and inferior. Coming into the greater tuberosity, the greater tuber. One of these things is not like the other. So if we come and sneak up underneath, we get subscapularis. Which I just lost. Subscap sneaks up from underneath, grabs on the lesser tuberosity, so it comes up from underneath the armpit to grab that lesser. So the principal roles, we call it the rotator cuff because it's rotating the humerus. The first three we typically tie into external rotation. Supraspinatus, infraspinatus, teres minor. You're coming from the back, grabbing around the outside to pull your arm externally. Subscap is the only one that comes up from underneath to grab the inside to pull it internal. So let's play a little game real quick. I want you to find a partner. Look at your partner. Say hi. Hi. How's it going? Dominic, go over. Rachel, real quick. Seems how Juliet is. She's throwing it. Whatever. That's fine. Take your arms, keep your elbows at your side. Put your hands out in front of you. Just one of you, one of the pair. Okay? Unless you really want to play rock, paper, scissors or something. Good joint or be social. Okay. So, the person holding here is going to be my patient, and the person who is testing will be my tester. So my tester, put your hands on the outside of their hands. And I want you to try to push their hands together. I want my patient to push their hands apart. So elbows tucked in, we're doing rotation. Externally rotate against resistance. Feel that strength. Find their break point. Okay. Now, slide your hands as the tester to the inside. Push out to where my patients are pushing in. Which one is stronger? Internal or external? Which one do you think is stronger in this position? Internal rotation is quite a bit stronger. Does that seem weird to anybody? Seems weird to you. Why does it seem weird to you? Well, because you're not feeling it quite that strong. Good. On the inside. How many muscles create external rotation? Three. supraspinatus, infraspinatus, teres minor. The three that grab on the greater tuberosity. How many muscles create internal rotation? One of the rotator cuff. So, subscapularis. So why are you stronger on internal rotation? I mean, it's 1 versus 3, and it's pretty much the same land mass. I have the subscapular fossa as compared to the supra and infraspinous fossas. So, 3 muscles yanking on it, plus teres minor thrown in there. So why are you stronger on internal rotation than you are on external rotation? Because something else is facilitating. There's something else going on. So we have another muscle that's got leverage to do some of that rotation work. So in the hip, we talked about how some muscles, based upon body position, have an influence in certain motions, and so it gets a little more convoluted. And this will be one of those cases. Pec major comes across, so in this position, it's got leverage to pull in. It's grabbing the humerus to rotate it in. So try this out. Have the patient put your arm up at 90 degrees, hand out straight. And I want you to stabilize the elbow a little bit. I want you to have them focus on trying to internally, don't let them adduct, don't let them pull down, but internally rotate against resistance. And are they stabilized? Just underneath, like, and then put your hand here and have her push against your hand. And then actually have her abducted in that. There you go. And are they nearly as strong here on internal rotation as they are here? Because it takes the pec out of a line of pull, so it can't help so much. So these are things that you kind of, the difference is when you're playing with muscles and the body positioning helps you to discern the involvement of one versus another. Okay. Rotator cuff has a secondary function, something that is very important to understanding how to stabilize and work with shoulder instability. So I've got 3 muscles that wrap and grab from the posterior side. I got to dig them out again. Okay. I'll highlight these 3. I highlight subscap. That's the vast majority of that humeral head that is in fact covered by tendinous attachments. So that rotator cuff is grabbing all of that humerus and pulling it in towards the body. So what's it doing? Yeah, it stabilizes the head of the humerus. I mean, it creates a compressive force to hold it in place. So go back to this position here, much like you'd be throwing a baseball. That humeral head sits in that joint capsule. The subscapularis comes up from the inferior, almost at a directly upward, to grab that lesser tuberosity to pull it down. So it's active to help hold the humeral head down in the joint where normally it might try to slide or shift up. Have a pitcher throw 100 pitches. You fatigue the subscap at that level, and you better believe at the end of those pitches, there is an increased likelihood that humeral head will just shift ever so slightly up. What's above it? What is up? What's above the humeral head? Scapula. What landmark? We've got this bridge sitting right here. That roof line that we've talked about before. That roof line is the acromion with the what ligament? What ligament completes the acromion roof, acromion archway? The coracoacromial ligament, the funky one that attached 2 landmarks on the same bone. Coracoid process to the acromion process. Creating the roof to keep us from rolling off of the glenoid. If that humeral head shifts up, then it's pushing up into that space. So next question then is, what's in that space? Is it just pushing bone into bone? And the answer is no. There's some soft squishiness in between. There's a muscle in there. What muscle's in there? What muscle's in there? You can see it.
Supraspinatus.
Supraspinatus. Muscle sits right there and hides. Sits right on top of the head of the humerus. So if I'm elevating that, that humeral head is shifting upwards. Well, yeah, there's a good chance that it's going to start crushing on that. If I dig that out one layer more and hide the supraspinatus, let me introduce you to the long head of the biceps tendon. So again, you felt it here. Externally rotate, intertubercular groove. You can feel it. It goes up to the top of the glenoid on the supraglenoid tubercle. So that's actually underneath that subacromial arch, that acromial archway. So I have a tendon that sits in that exact same spot, attaching to that supraglenoid tubercle, the bump on the top of the glenoid rim. Now to get to all of this, I also had to go and hide out the subacromial bursa. What's a bursa do? What's that? Lubrication. It helps where there's going to be friction. It helps prevent too much friction. Like supraspinatus muscle under a bone, it helps lubricate that. So we have three things in this subacromial space: supraspinatus, long head of biceps tendon, and subacromial bursa. There's a condition called impingement in which these structures are getting squished by the humeral head pushing up into that acromion, which is crushing any one of these three or all of these three and causing damage. Now it could be that damage coming from the acromion pushing downward from the top, or those muscles, those entities getting squished into the edge of the labrum itself. So I could damage it from the underside, off the glenoid, or I could damage it from friction off the top in the acromion. More fun stuff you'll play with in ortho. But that's where this is coming from. So that joint compression component, to bring it back to that, is necessary so we can hold that humeral head stabilized in place as it dynamically moves through a very wide range of motions. So rotator cuff is not just rotation. It's stabilization of that humeral head in the place. So a lot of times if you have gross instability, multidirectional instability, MDI of the glenohumeral joint, then we need to work on a dynamic control, because that means your ligaments are too lax, too stretched, too loose to hold the head the way it needs to. It shifts around too much. So we need the muscles to pick up their activity to do more. So again, it leads you into a direction of how we might rehabilitate a shoulder. Because we have scapular stabilization, we have to have that scapula set. We have to control that glenohumeral joint, so we have to control those muscles, or encourage those muscles to control the humeral head in and around that glenoid, or we get some issues. So taking a basic, here's where the muscles are, and putting it into an understanding of when you're going to see an application and ways that you can intervene in rehabilitation matters a lot. So, group number 2, rotator cuff, supraspinatus, infraspinatus, teres minor, subscapularis, your sits muscles. 3 of them are external rotators, 1 of them is an internal. All of them work together to stabilize the humeral head as a compressive force. Take a peek at supraspinatus again real fast. Let me get Terry's trapezius out of there. Especially on the shoulder, I'm going to encourage you to practice putting your hands, your fingers, at origin and insertions. because it will give you a better reinforcement of what motions you'll get out of it. So if I grab pecs, sternum, into humerus, and we'll get to that in just a minute, but if I pull it, you can kind of imagine that it's pulling that humerus across. Make sense? Try that with supraspinatus. You go over the top, supraspinatus fossa, and you go straight over the top onto that greater tuberosity. Pull them together. What motion do you get? You want to lift your elbow up. That makes it a very funky external rotator, doesn't it? Because it's not giving me any leverage at this position to create external rotation. It's an abductor. Well, sure enough, one of its principal functions when it's firing most is from 0 to 15 degrees of abduction. Eccentrically, if I throw a ball, as I come forward, now it has more line of pull to give me pull back. So it eccentrically, as it's elongating, slows my arm in a throwing motion. So from that midpoint forward, it will be more active as an external rotator. Otherwise, it's going to have more pull in abduction, but it will always have that compressive force to stabilize the glenohumeral joint. Okay, so where does that get us? How many muscles scapular stabilization? 6. What are they? Trapezius, rhomboid major, minor, levator scap, serratus anterior,
and pec minor.
and pec minor in the front, right? Now, pec minor is the one people like to forget about because it's not the same. So ribs 3 through 5 coming up to the coracoid process. How many muscles make up your rotator cuff? 4. Supraspinatus, infraspinatus, teres minor, subscapularis. 3 of those, the first 3 of those, external rotators, with all supraspinatus' unique quirky behavior, 0 to 15 abduction. Subscapularis, internal rotation. So we're going to look at 7 more muscles. And those 7 are larger muscles that you probably should have by this point in your life heard of. Most of them anyways. And these are ones that are going to be primary movers of the glenohumeral joint. So this is going to give you your range of motion. So we're going to try to lump these into 3 separate groups. Not by motion and action like we've done before, but we're going to do them by location. But let me pause for a second and clean up motion and action. Because what I learned from yesterday is some of these actions are apparently not very comfortable for people. So let's clean that up. What actions, what motions, like we've done before, what motions do we have at the shoulder? How many planes does it work within? How many degrees of freedom do we have? How many degrees of freedom at the shoulder? How many can we have? 3. We have 3. So focus on degrees of freedom. Keep your happy number self down. Degrees of freedom. Those are related to the planes of motion we have, right? So frontal, sagittal, transverse. We can move within any of those, right? Okay, so frontal plane, here, touching a wall of glass all the way out. What motion is that? Abduction, abduction, taking it away, adding it back in, adduction. We can move within the sagittal plane and stay in contact. What is that?
Flexion, extension.
Flexion and extension. We can rotate. So I'm touching the transverse plane the entire time. So in this position, that's transverse plane. What about this? Which plane is this? It's transverse. What motion is this? This is the one that kind of throws and bothers people. So instead of vertical, it's horizontal. horizontal adduction, horizontal abduction. Horizontal, plane. Horizontal motion, adduction, adding it back in, and abduction.
So those are counted as the two extra movements. You have 6 altogether. Right?
So 1, 2, flexion, extension, abduction, adduction, 3 and 4, internal, external, 5 and 6,
Okay.
and then 7, 8. You could add in 9 because you can do circumduction.
Yeah, it's the same. We talked about circumduction.
So we can do this, which is circumduction. We can just pivot, spin it in place.
Okay.
Which really, well, yeah. Okay. All right, so the problem is, for me to sit there and break this apart by motion, it's going to bother you because there's a lot of overlap. I have 7 muscles to create what we just decided was 8 motions. 9 if you added circumduction. So let's do that a little bit differently. So we're going to talk about anterior muscles, superior muscle, and posterior muscles. So we'll put them in location groups. And then again, my strong encouragement is to touch an origin and touch an insertion and pull your fingers together to kind of get a feel for, physically, reinforcing what that motion will end up being. Because the ones that create forward flexion will also probably create horizontal adduction. If you do it this way, then it's less stressful. Okay? So we'll get over the top first because that's the easiest. So this is your deltoid. Ever been in a gym, weight room, done a weight exercise? What exercise do we have for the delts? So we can do overhead military press. We can do delt raises coming up and across. Good? And you can feel it. So the origin of the deltoids. There are 3 heads to the deltoids. There's an anterior, a middle, and a posterior. So the anterior is coming off the distal third of the clavicle. The middle is off a little bit of that distal clavicle, mostly on the acromion and over the AC joint itself. The posterior is spinous scapula. Now, take your arm, find that, but contract it under your hand, and you can feel the convergence as all of those bellies draw to a point right there. So you can feel that convergence point right in here. So contract it, find that insertion point, then relax and run your finger up and down a little bit, and you'll realize there's a bump there. That's the deltoid tuberosity. Yay for simple. Deltoids insert on the deltoid tuberosity. If you can't find it, let me know. You got it? No? So, come down. Push that against my head. So you can flex. You can feel the deltoid. Just slide away. And then if you come right in there, relax. In there. Okay. You'll feel the bump. That bump on that humerus, that kind of tender spot right there. That's your deltoid tuberosity. Kind of sort it out. Good? So, if you do that hand trick, you start with the origin, start AC joint, distal acromion, go towards that deltoid tuberosity, and you try to squeeze your hands together, it's going to abduct your arm. Those 3 heads together work to abduct your arm. Grossly assisted from 0 to 15 by supraspinatus. But it carries that weight all the way up to 180 degrees. But since we have 3 heads, and they are originated in 3 different places, we have 3 different angles of pull. So all 3 of them working together are going to give me abduction. But what happens if I fired my anterior delts in isolation from my posterior? So anterior delt coming off that distal clavicle, going here to that deltoid tuberosity, and if I pull, it's going to give me forward flexion, or it's going to give me horizontal adduction. So if I fire my anterior chamber, my anterior compartment muscle, it's going to move me anteriorly in one of those manners. Likewise with posterior. If I fire my posterior delt, it's going to give me some extension. It's going to give me horizontal abduction. So less of a rote memorization and more of logically just think through it. The muscles on the anterior placement are going to give me motions in the anterior direction. And recognize that what those motions are. Flexion, horizontal adduction, potentially some adduction coming in. Okay, so what else do we have? Let's get rid of, I'm going to go front or back first? Front, good call. I like it when we can negotiate well together. Alright, so we're going to get delts out of the way because we got some fun happy stuff sitting here. Most obvious thing that we're staring at right now is your pectoralis major. We zoom out just a touch so we can see. So it goes across your sternum. Inserting into the shaft of the humerus. So I had a football player come up. End of the game. Guy was a chief paramedic at a local hospital. Semi-pro football. Guy was in his 30s. And near the end of the game, he comes up and he goes, so he's got a fair medical background, certainly not musculoskeletal in that sense, but he's a paramedic, so he's got some wits about him. And he goes, all right, I hit somebody. So I tried to shuck him off as the runner was coming around. So I pushed him off, dove, caught the ankle of the guy. As the guy pushed off, came back in. So that puts him in a position to where he's going here, he lunges, and the guy comes back in and bends him in half as his arm is thrown out this way. So he's like basically that. Now this is very close to a beautiful way to dislocate your glenohumeral joint. Abduction, external rotation. Humeral head. This guy was a former bodybuilder. Stout little dude. He goes, all right, I felt my shoulder dislocate, and when I hit the ground, I felt it pop again. So I think it went back in place because I can move it. It just hurts. So all of his pain is in the anterior compartment. He can move it. He says he's good. Game's over. He's going to ice it. He calls me up the next day, which is a Saturday. He's like, okay, there's a problem. Is it normal for the bruising to go down the shaft of my humerus? I'm like, no, probably not. Because the swelling and the bruising is going down my arm. So I'm like, all right, well, why don't you come in so I can see it? And I do. So yeah, clearly he's got this bruising coming down into here. So he avulsed his pec major off the bone. So rather than, he had the strength enough to preserve the joint, but the muscle gave way by the end of it. So instead of externally rotating, he was pulling straight horizontal abduction. So they had to go surgically repair, and because he was bodybuilder, or at least formerly a bodybuilder, he was very concerned about the appearance bilaterally of it showing and not having a deficit. Bless your heart, listener. Pec major. Pec major is a very unique muscle. It is giving us horizontal abduction. It is grabbing this bone and pulling it in horizontally to the midline. Push-ups. Bench press. I'm here, I'm pushing up. Flaps. I'm here, I'm pulling in. That is pec major in isolation. Now, if you recognize it has a very broad origination point and a very singular insertion. So as a convergent muscle, it's got a very dynamic movement pattern, much like the trapezius does. So if you go and you hit the weight room, you're going to see inclined benches and declined benches with people doing flies and bar presses of some kinds. Because it's helping to isolate the strength of the upper fibers and give definition to the strength of the lower fibers to alter the position to isolate those fibers away from the rest. So recognize that as we learn where they are, learning how to condition and train them becomes important. Where we have such a broad, multifaceted, multi-ability muscle, we need to strengthen that muscle throughout those ranges of motion if we're trying to get strength across their capacity. So, none of us are aiming to be personal trainers, but what we do as a personal trainer definitely falls in line with, well, what people do as personal trainers falls in line with how we recondition and help people, and certainly how we help prevent injury down the line. And then we've already had a discussion about how at this point it's also helping assist with internal rotation. You can't help but do that internal rotation test, put your hand on your pec and feel it contract. Now, out in the world at Starbucks, people are going to look at you a little funny when your hand's all over your chest and everything else trying to feel where muscles go. Nobody's paying attention when you're all taking the same test. So, no judgment. So, pec minor, hiding in underneath pec major. We've already talked about him. That leaves two muscles. One of them we've already started with in two different ways. So, this guy right here is biceps brachii. What's wrong?
Not pec minor.
Pec minor is scapular stabilizer because it's grabbing the coracoid to tip it forward. So it's not crossing the shoulder joint, so it's not acting on the humerus. So biceps brachii. Biceps means it has how many heads? Two heads. We have a long and a short, and the difference is probably millimeters. Short head originates on coracoid process. Does that cross the glenohumeral joint? Yeah. So coracoid process is the scapula, which is past the glenoid. So yes, it does. Long head, as we've discussed, originates at the supraglenoid tubercle. So to go find it, I actually need to slide in, hide out that bone. Let me highlight long head. You can see how it tucks up over the humeral. It goes through that intertubercular groove, tucks over the humerus, right into the superior portion of the glenoid, actually going into the labrum itself. So we start talking slap lesions when you get into ortho. Superior labrum, anterior to posterior. These lesions, some of these lesions, are coming from the biceps long head, pulling that labrum off the bone. So we're getting tears that are the superior portion from anterior to posterior. It's pulling the labrum off, destabilizing that biceps. Ouch. So recognize its importance as you go into looking at those injuries. Now we have a ligament that we haven't really talked about before because I want to wait till we had biceps long head in, and that's this guy right here. So the transverse humeral ligament, it just covers that intertubercular groove. It holds the biceps long head in place as it goes to that groove. It just sits on top. It is possible to rupture, it is possible to displace the biceps long head tendon. All right, the insertion of the biceps brachii, radial tuberosity, on the radius, which means it's crossing the elbow. So biceps brachii, the whole thing, both heads, two joint muscles. Crosses the humerus, crosses the glenohumeral joint, crosses the elbow, humeral ulnar joint, or radial joint.
Elbow.
Elbow and the shoulder, right? So its principal action when we work it out is elbow flexion. It is our primary elbow flexion. But if you go and try that trick again, coracoid process down across as far down your humerus as you can reach, and you grab, you're going to be pulling that humerus forward into flexion. If you are abducted, you will horizontally adduct it. So again, anterior compartment is doing forward flexion, horizontal adduction. One last little muscle. So here's short head right here. Got them both highlighted. Cut them out of the way and sneak it up underneath is coracobrachialis. So coracobrachialis, coracoid process. It's about mid-shaft of the humerus. Yes, ma'am.
Should we count differently the long head and short head?
In this case, keep them as one. I mean, they do have different origins, same innervation, same actions, more or less. When we talk about them, especially in the injury standpoint, we'll separate them because long head causes very unique injuries.
But as the group of the 7 together.
Which it's one, biceps brachii. So we've done deltoid so far, biceps brachii, coracobrachialis, pectoralis major. That's 4 of the 7. So coracobrachialis, coracoid process, shaft of the humerus, boom. And you get forward flexion, you get horizontal adduction. Good? So we've done superior deltoid. We've done the 3 that are on the anterior side. So let's flip over and chat posterior. First thing you see is posterior delt sitting right in front of you. It's going to help with external rotation a bit. It's going to give me some extension. It's going to give me some horizontal abduction. So again, a little harder to grab this one, but you definitely get the feel for the things that it's going to do. Posterior motions. How many muscles should be left?
2. 3.
You gotta work on your math. 3 in the front, 1 over the top, deltoid. We have 7 total.
Deltoid is not part of the anterior.
Deltoid, so that's going to be our superior. So the anterior delt's going to be part of it, but the posterior delt's going to be part of the back. So we'll count it as 1 going over the top. So we have deltoid here, pec major, biceps brachii, coracobrachialis. In the back, we're going to add in teres major, inferior angle of the scapula, coming out to the shaft of the humerus. Very much an adduction muscle. What resisted exercises can you think of that would be glenohumeral adductors? What does that look like? And I'm trying to pull it in. What motion is that? So, horizontal, or not horizontal, but glenohumeral adduction. I'm pulling the humerus back into the midline of the body. What type of action is that? What type of exercise do you know of that creates that action? What type of motion is that? What does that look like? Like, what exercise would you do? You're exactly right, but what exercises are those? Hey, how you doing? But so jumping jacks, yeah. I mean, you're adducting, you're pulling it in. What's a bit more dynamic? How do we make that harder? How about a pull-up? You grab a bar, you pull up by adducting forcefully pulling that humerus back into your body. So we're here, we pull here. You go in the weight room, you grab a bar, you do lat pull downs. That's teres major, in large part, in support. But the fact that it's lat pull down, what else is it primarily? Latissimus dorsi. So your latissimus dorsi is this huge, massive band of muscle that covers the majority of your back, that comes up underneath as well. So posterior, teres major, latissimus dorsi. Latissimus dorsi is coming off the spinous process. Man, T7 all the way down to the sacrum. Iliac crest on part of that. All of that blending up into the head of into the humeral shaft, proximal humeral shaft. So that leaves one muscle left. We had biceps brachii. We can add in triceps brachii. But just one head. So in the triceps, we have medial, lateral, and long. Long is the only one that crosses over the shoulder joint, over the glenohumeral joint. But again, it's going to assist with horizontal abduction. It's going to assist with a little extension. It's going to assist with some adduction. Insertion is going to be olecranon process. That's the bump at the tip of your elbow on the ulna. So principal action for the triceps is elbow extension. But long head also has an action at extending and moving the humerus into the posterior quadrant. How's that feel? Doing okay? Brain hurt yet? Yeah? 11 muscles? Feel worn out? Wait till next class. So what do we have left? So let's draw some parallels here. The hip, very complex, lots of motion. The shoulder, very complex, lots of motion. More complex, lots of motion. More complex in its own ways because of the dynamic nature of its movements. Okay. The knee, flexion extension, less dynamically mobile, fairly simple muscles to understand flexion extension. We're going to get the same thing with the elbow for motion's sake. But we have a unique motion. So at the knee, we had a little bit of rotation, right? What was that called? What's the rotation at the knee called? Come on now. Well, why do we have it? What's it called? Oh wow, wasn't that long ago. What is it and why do we have it? Screw home mechanism. What is it for?
So we don't get tired.
Yeah, so it locks the bones together so we can stand upright without fatiguing our muscles, right? So we have a little bit of rotation. We have a lot of rotation at the elbow. We have pronation, supination at the elbow. So we've got to work through that. We actually have 3 separate joints that make up the elbow itself. 3 separate articulations that make up the elbow joint. So we'll go through that. We won't touch it today because I'm just giving you a little bit of heads up. But the flexion extension part, that's triceps, and that's 3 muscles for flexion. Biceps brachii is one of them. So we've already covered 1/3, 2/3, 2 out of 4 of the muscles that give us flexion extension. What's going to drive you nuts is your forearm. So the forearm is synonymous with the lower leg. It's all the musculature that's controlling the wrist and the fingers. So like in the lower leg, we had the calf, the 4 compartments that made up all of the inversion, eversion, plantar flexion, dorsiflexion, toe extension. That's going to be the forearms. So there's going to be a lot of muscles. They're all overlapped on each other, but there's a few, quite a few. Then we're going to get to the hand, the wrist and the hand, before we're done. And that wrist and hand, we're going to have intrinsics. And a lot of those, down to the lumbricals, the worms, they'll be the same names. Very little changes as compared to the foot. So it's not overly traumatizing. Okay? But we need to get them understood well, because the injuries that you get in your hand, we need to know them very well. Because some of them are much more emergent than others in terms of how we have to get them resolved. Okay? That's largely, I think, going to tie up this testing session. If we can get to it, we'll do brachial plexus. So let me divert for a second, so we can talk about final exam. Well, not exam, but the third exam. I'm moving the test date for everyone, which is different than what I discussed with a couple of people yesterday, the day before, something. So this schedule we have here. Thanksgiving week. Thanksgiving week is 20th through the 26th, right? So we're class here, and your exam is slated right here for the day before Thanksgiving. Okay, we're moving it back to the 17th, forward to the 17th.
2 weeks.
What's that?
2 weeks.
2 weeks. So today's the 3rd. We have the 8th, the 10th, the 15th before we get to the 17th. We will finish through the hand and fingers by the end of the day of the 10th. So 2 more class periods. So elbow, forearm, hand and wrist, intrinsics between 2 days. Not a nightmare. But that leaves you through the weekend. Whatever we cover on the 15th, I won't add on to the exam. So we will use it primarily initially as review time for those who have questions, want to recover some concepts, whatever we need. If we don't, then I might slide in a couple of the pieces that go towards the final. Because we're going to have to get into the nervous structure, the brachial plexus, and then some of the nerve pathways.
So we won't be able to do like the 20 points.
It will go on to the final, if it doesn't go on to this one. Okay. Your exam will be the 17th. The last day to drop this class is the 18th. And that's why we shift this class. That's why we're shifting the exam date. So you have that information before you leave before you have to have it for the last day to drop. It also means that when everybody else is giving you a test on the Monday and Tuesday before Thanksgiving, I'm abusing you a couple of days earlier.
Yeah, I was going to say, are we going to have class edit?
Which one?
22nd.
There will be modules posted online to make up for the fact that we will not be in here. So we won't be in class on the 22nd. Okay? But I will build some online modules that will probably be the brachial plexus drawing, or walking you through, talking you through how to create it, construct it, so you can work on it. So I will post things for you, but you don't need to be here for that day. Okay? Okay. That means we have the 29th and December 1st as our last days in class. I anticipate those. Again, we've got to clean up the nervous structure and the arterial structure, but it's not a lot. I say that, anybody listening to that recording later in life is going to cringe like that. But for the parts that we're going to principally go into, arteries and palpation for emergency purposes, and certainly the nervous structure, simplifying that down to what's beneficial and simple for us. And then review, and then your exam is actually on, I believe, the 8th, the Thursday of finals week. If you would like, the other class's exam is on the 5th. So depending upon your individual exam schedule, I don't care if you show up on the 5th. So if that clears you a day earlier, or if you want more time to study for this one, whatever floats your boat.
I'm sorry, what was that?
So your exam is on December 8th,
For the
final,
Mm-hmm.
but the other class I'm giving on the 5th.
Okay.
So if it fits in your schedule for you to take it here, then because you want to leave earlier, it's fine with me.
I have 2 finals on this.
But if that doesn't work with you, I'm certainly not saying that's what you have to do.
Okay.
You're perfectly fine. I'll be here. They don't let me leave. So Any questions? Are we all good?
So, class the 22nd is optional.
Class on the 22nd is non-existent.
Okay.
We will not be in this room.
Okay.
You will have modules for those lessons.
Okay.
So I will create lessons that you can do from wherever you want to be at whatever time you want to do them.
Okay.
That material will be included on the final exam.
Okay.
Okay?
Got it.
So, I think the nervous tissue structure, in large part, we can get done between the 15th and the 22nd. Good to go? Okay.
What is that?
Your full comp is December 2nd. So it's the Friday before finals.
Okay, good.
So I wanted